All right, getting ready to dive deep into cardiac amyloidosis for you this time.
Yeah, it looks like you've been prepping for this one.
Definitely some intense medical lecture excerpts in the source material.
Yeah, but complex stuff, that's what we're here for, right? Break it all down.
Find those aha moments.
Exactly, so no one feels overwhelmed, just
I
informed.
like that. Informed, not overwhelmed. That's us.
What I think is so interesting about cardiac amyloidosis is that it's often missed.
Really? Like misdiagnosed?
Yeah, it can mimic other heart problems, so it can be tough to catch early on.
So we'll make sure our listener knows what to watch out for.
Yep, we'll cover those subtle clues and all the different ways it can impact the heart.
Okay, so first things first. What exactly is amyloidosis?
Well, you know how proteins are these essential building blocks in our bodies?
Yeah, doing all sorts of important jobs.
Right. Well, in amyloidosis, those proteins, they misfold.
Misfold. What, like a bad origami project?
Perfect analogy. Imagine a perfectly folded origami crane, suddenly a jumbled mess.
Okay, I can picture that.
And these misfolded proteins, they clump together, forming these sticky fibers.
Sticky fibers, huh? Those sound like trouble.
They are. We call them amyloid fibrils. And they build up in tissues and organs, interfering with how things should work.
Not good. And today we're zeroing in on the heart.
Right, cardiac amyloidosis, those sticky fibrils are messing with the heart muscle cells, making it harder for the heart to do its job, pump blood effectively.
Got it. So the lecture mentions different types of cardiac amyloidosis. Is it just one specific protein that goes haywire or what?
Good question. There are actually a few types, and each is a little different.
Okay, well, let's break them down then. What's the most common one?
The most common type systemically is called AL amyloidosis.
AL amyloidosis. What does that stand for?
It stands for amyloid light chain amyloidosis.
Light chain. Wait, those are part of the immune system? Right.
Exactly. AL amyloidosis actually starts with the immune system, specifically these cells called plasma cells.
Okay, so the immune system can actually cause this. That's unexpected. Tell me more about these light chains.
Sure, so these plasma cells, they normally produce antibodies, which are these proteins that help fight off infections.
Right, antibodies, those are the good guys.
Exactly, but in AL amyloidosis, the plasma cells start making these abnormal light chains,
Abnormal meaning?
meaning they misfold and they turn into those sticky fibrils we talked about.
Ah, so those are the culprits. And you mentioned monoclonal protein earlier. What's that all about?
Great point. I should have clarified that. Monoclonal means coming from a single source, like a single type of cell.
Okay, so in this case, it's those abnormal light chains that are all coming from the same messed up plasma cell.
Precisely.
Hmm.
And detecting this monoclonal protein in the blood or urine, that's a key part of diagnosing AL amyloidosis.
Ah, so it's like a fingerprint pointing to those rogue plasma cells.
Mhm.
And you mentioned AL amyloidosis can affect more than just the heart.
You're right, it's systemic. So it can impact a bunch of organs, the kidneys, liver, nervous system, spleen.
Wow, so a whole lot of potential complications there. What kinds of symptoms might someone with AL amyloidosis experience?
Well, because it can affect so many different organs, the symptoms can vary a lot. But some common ones include fatigue, weight loss, and problems with the kidneys.
Okay, those sound pretty general. Anything more unique?
Well, there's one unique sign called raccoon eyes. Have you heard of that?
Raccoon eyes. Okay, now you have to explain that one.
It does sound strange, but it's actually what it sounds like. Bruising around the eyes.
Seriously, why does that happen?
It's because the amyloid deposits, they weaken the tiny blood vessels under the skin, making them more prone to bleeding.
Wow, so a little bit of trauma and bam, raccoon eyes.
It's not always present, but it's definitely a striking clinical sign when it is.
Fascinating and kind of scary at the same time. Okay, so we've got AL amyloidosis caused by these rogue light chain proteins. What about those other types mentioned in the lecture?
Right, the next one is ATTR amyloidosis. In this case, the problem is a protein called transthyretin,
Transthyretin, okay. Say that 3 times fast.
or TTR for short, much easier.
TTR, got it. What does
Yeah.
it do?
It has an important job transporting vitamin A and a hormone called thyroxine throughout the body.
Okay, sounds important. So what goes wrong with TTR in ATTR amyloidosis?
Well, it misfolds, just like those light chains in AL amyloidosis. But there are actually two subtypes of ATTR amyloidosis.
2 subtypes. You're going to have to
Yes.
break that down for me.
Of course. There's ATT-WAPREVITY, which stands for wild type, and ATTRV for variant.
Okay, wild type versus variant. What's the difference?
The difference is in the TTR protein itself. In ATTRV, the protein is normal, but it still misfolds. This usually happens in older adults.
So it's like age makes the protein more likely to fold incorrectly.
Exactly. It's like that origami crane that's been folded and unfolded so many times it loses its shape. But in ATTRV, there's actually genetic mutation in the TTR gene.
Ah, so the protein itself is inherently unstable, more prone to misfolding.
Right. And that type is hereditary, passed down through families.
Okay, so one is age-related, the other genetic, and they both lead to amyloid buildup in the heart.
Precisely. And like AL amyloidosis, ATTR can also affect other organs, especially the nervous system and soft tissues.
So diagnosing this, especially the wild-type form, must be tricky.
Yeah, especially if it looks like something else and happens more in older folks, easy to miss.
Right, doctors might just chalk it up to aging or something.
The lecture actually mentions that ATTR gout is often misdiagnosed
Really? Why is that?
because patients can seem clinically better than their imaging results would suggest.
So they might not have many symptoms, even though the amyloid buildup is pretty bad.
Exactly, so it's not always obvious.
Wow, that makes things tough for doctors. Any other clues that might specifically point to ATTR?
Well, one interesting thing is that carpal tunnel syndrome can be a common early sign.
Wait, carpal tunnel. That's a hand problem. What does that have to do with the heart?
Remember, ATTR amyloidosis can affect soft tissues, and that includes the carpal tunnel.
Ah, so those amyloid deposits can build up in the wrist and cause those carpal tunnel symptoms.
Exactly. So it's something to consider, especially in older patients with heart issues.
Okay, so if someone has heart problems and a history of carpal tunnel, that's a red flag.
It's definitely something to think about. And knowing a patient's ancestry can also be helpful.
Ancestry. How so?
Certain TTR mutations are more common in specific populations. For example, the VAL122IL mutation is more prevalent in African Americans.
Interesting. So ancestry can play a role.
Yeah.
Now, the lecture mentions a third type, AA amyloidosis. Fill us in on that one.
Sure. AA amyloidosis is less common, and it rarely affects the heart directly.
Oh, so it's not a big player in cardiac amyloidosis then.
Right. It's usually a complication of long-term inflammation or infection.
So the body's response to those conditions can trigger this type of amyloidosis.
Yeah, essentially. The body produces a protein called serum amyloid A in response to inflammation, and that protein can misfold and form those sticky amyloid deposits.
So it's not the primary problem, but rather a consequence of something else going on in the body.
Exactly. So we've got AL, ATTR, and AA amyloidosis all leading to this amyloid buildup.
All right, good overview. But the lecture talks about how often cardiac amyloidosis is missed. So how do doctors even detect this thing? It seems like it can be tricky.
Yeah, you're right. It's not always easy.
Like we said, fatigue is a common symptom, but who isn't fatigued these days? So how can doctors differentiate that from something more serious?
You've hit on a key point. The lecture actually highlights three main reasons why cardiac amyloidosis is often missed. First, there's this perception that diagnosing it requires specialized centers and a procedure called an endomyocardial biopsy.
Endomyocardial biopsy. That doesn't sound fun.
It involves taking a tiny tissue sample from the heart muscle to examine under a microscope.
Okay, so not a routine test.
No, it requires specific expertise, so not all hospitals can do it.
Right, so access to specialized care might be one barrier. What's the second reason?
The second reason is the tricky nature of the symptoms.
Right, we talked about fatigue, shortness of breath, edema. All those can be caused by a lot of different things.
Exactly, and those symptoms are also common in other heart conditions, especially in older adults.
So it's easy to see how doctors might attribute those symptoms to something else, especially if they're not thinking about amyloidosis as a possibility.
Precisely. And the third reason is that until recently, there weren't many effective treatments for cardiac amyloidosis.
So I guess it seemed less urgent to make a definitive diagnosis.
Right, but now with new therapies emerging, that's changing.
So early diagnosis is becoming even more important.
Absolutely.
Okay, so that makes sense. But how do doctors actually detect this? Are there any blood tests that scream amyloidosis?
Not quite a screaming headline, but there are some things to look out for.
Like what?
Persistently elevated troponin and natriuretic peptides, those are red flags.
Okay, so markers of heart damage and stress. Not specific to amyloidosis, but definitely worth investigating further. What about imaging?
Imaging is where things get really interesting. The lecture mentions a bunch of different tools, from a basic ECG to more advanced scans.
Let's start with the ECG. What kind of patterns would point towards cardiac amyloidosis?
One classic finding is what we call a low-voltage ECG, especially when it's seen along with thickened heart walls on an echocardiogram.
So the heart is electrically quiet even though it's physically big?
Exactly. And it's those amyloid deposits that are causing this. They mess with the electrical signals, hence the low voltage, while also making the heart walls thick and stiff.
Ah, so it's a bit of a paradox. What about echocardiography? It sounds like that's a key tool for diagnosing cardiac amyloidosis.
Absolutely. Echocardiography uses sound waves to create images of the heart in action, and it can show some very specific signs of amyloidosis.
Like what? What are we looking for here?
Well, thickened heart walls are a big one, as we mentioned, but it's not just the thickness itself, it's also the pattern. In cardiac amyloidosis, the thickening often goes beyond just the left ventricle, involving the right ventricle and even the atria.
So it's more widespread than you might see in other heart conditions.
Exactly. And then there's the size of the left ventricle cavity. In cardiac amyloidosis, this chamber is often small because the amyloid buildup is restricting how much blood it can hold.
So it's like the heart is being squeezed from the inside out. Are there any other telltale signs on an echocardiogram?
Yes, there's what we call the filling pattern, which basically describes how the heart fills with blood when it relaxes between beats.
Okay, filling pattern. How does that work?
In cardiac amyloidosis, we often see a restrictive filling pattern. It means the heart is having trouble filling with blood because the amyloid buildup is making it stiff and unable to relax properly.
So it's like trying to inflate a balloon that's already stiff. It doesn't want to stretch.
That's a great way to think about it.
Okay, so we've got thickened walls, a small left ventricle, and this restrictive filling pattern, all pointing towards cardiac amyloidosis.
You got it. And there's even more. Newer techniques like strain imaging can show a unique pattern called apical sparing.
We talked about apical sparing before, right? It's like the tip of the heart is somehow resisting the damage.
That's right. It's like a castle under siege. The walls are crumbling, but the highest tower is still standing strong.
I like that visual. So apical sparing, that's another clue that can help differentiate cardiac amyloidosis from other conditions.
Exactly.
All right, so echocardiography gives us a lot of information. But the lecture also mentions cardiac MRI or CMR. What's that all about?
CMR uses magnetic fields and radio waves to create really detailed images of the heart, and it's super valuable in diagnosing cardiac amyloidosis.
Okay, what makes CMR so special for diagnosing this?
Well, one of the biggest advantages of CMR is that it can actually visualize the amyloid deposits themselves.
Wait, we can actually see the amyloid buildup in the heart?
Yes, CMR uses a contrast agent called gadolinium, which highlights areas of abnormal tissue.
So it's like highlighting the problem areas, making them stand out from the healthy tissue.
Exactly. And the pattern of this enhancement, which we call late gadolinium enhancement or LGE, can be very specific for cardiac amyloidosis.
Okay, so that's really helpful in confirming the diagnosis. And I guess CMR also gives you a very detailed look at heart function, right?
Absolutely. CMR can show you how well the chambers are contracting and relaxing, whether there are any blockages in blood flow, and so on.
So it's like a comprehensive heart checkup, but with a special focus on those amyloid deposits.
Exactly.
Are there any other imaging techniques mentioned in the lecture?
Yes, the lecture also talks about nuclear imaging.
Nuclear imaging. How does that work for diagnosing cardiac amyloidosis?
Well, certain bone-seeking tracers, they have this unique ability to bind to amyloid deposits in the heart.
Bone-seeking tracers. I wouldn't have thought of that.
It's pretty cool. These tracers, when we inject them, they accumulate in areas where there's amyloid.
So it's like a homing beacon for amyloid. And if you see that signal in the heart, it's a strong clue that it's cardiac amyloidosis.
Exactly. And not only can it detect the amyloid, it can also help differentiate between the types. The tracers bind much more strongly to ATTR amyloid than to AL amyloid.
Ah, so that's valuable information for deciding on the right treatment since different types need different approaches. What are the advantages of using nuclear imaging?
One big advantage is that it's non-invasive.
So no needles or biopsies or anything like that?
Right. And it's also very sensitive, meaning it can detect even small amounts of amyloid.
Okay, so we've covered ECG, echocardiography, CMR, and nuclear imaging. Quite the arsenal of diagnostic tools.
Definitely a lot of options.
Now, earlier we talked about endomyocardial biopsy, which is considered the gold standard. When would a biopsy actually be necessary?
Yeah, a biopsy is really the only way to definitively confirm the diagnosis.
That's the ultimate proof.
Exactly. And it's especially important when imaging findings are unclear or when we need to figure out exactly which type of amyloid protein is involved.
Okay, so it's kind of like the final piece of the puzzle, but only if needed.
Right. And the lecture also mentions that other biopsies, like a fat pad aspirate or a bone marrow biopsy, can be helpful in diagnosing AL amyloidosis specifically.
Okay, so different biopsies for different types. Makes sense. What about genetic testing? When does that come into play?
Genetic testing is really important in ATTR amyloidosis, especially the variant type, ATTRV.
Right, that's the one caused by mutations in the TTR gene.
Exactly. So genetic testing can confirm the diagnosis, guide treatment decisions, and help us assess the risk for family members.
So it's not just about the patient themselves, it's about understanding the potential impact on their family.
Precisely.
All right, so we've covered a lot of ground on the diagnostic front. Now let's talk about treatment. What are the options for someone diagnosed with AL amyloidosis?
The main goal with AL amyloidosis is to target those plasma cells that are producing those problematic light chains.
Right, those are the troublemakers.
Exactly. And chemotherapy is the primary way to do that.
So you're going straight to the source, trying to shut down those malfunctioning factories. What kind of chemotherapy is typically used?
It depends on the patient and how severe their condition is. But one common approach is high-dose chemotherapy with a drug called melphalan combined with a stem cell transplant.
Okay, stem cell transplant. That sounds intense.
It is a pretty big deal, but it can be very effective. Essentially, the high-dose chemotherapy is like wiping out the bone marrow.
The bone marrow, that's where blood cells are made, right?
Right. So before the chemo, we collect some of the patient's own stem cells.
Stem cells, those are like the master cells that can turn into all the different types of blood cells.
Exactly. And after the chemo, we give those stem cells back to the patient.
So it's like a reset button for the bone marrow, wiping the slate clean and letting those healthy stem cells rebuild everything.
Exactly. And this approach has been pretty successful in a lot of patients with AL amyloidosis.
That's good to hear. Any other treatment options for AL amyloidosis? I know the lecturer mentioned some newer therapies.
Yes, there are a couple of new types of drugs that are showing a lot of promise. One type is called proteasome inhibitors.
Proteasome inhibitors, how do those work?
Well, every cell has these things called proteasomes, which are basically like garbage disposals. They break down old or damaged proteins.
Okay, cellular garbage disposals. I like that.
So these proteasome inhibitors, they block those garbage disposals in the cells.
And that specifically targets the plasma cells.
Right. It turns out those abnormal plasma cells are very sensitive to proteasome inhibitors. When their garbage disposals get blocked, they basically self-destruct.
So it's like overloading the trash compactor, causing those cells to explode.
Exactly. And these proteasome inhibitors, they're often combined with melphalan and another drug called dexamethasone, and this combo has been very effective.
Okay, so that's one promising approach. Any other new drugs out there for AL amyloidosis?
Yes. There are also these drugs called monoclonal antibodies.
Monoclonal antibodies, those are designed to be very specific, right? Like targeting a particular protein or something.
You got it. These antibodies, they specifically target a protein called CD38, which is found on the surface of plasma cells.
So it's a very targeted attack on those cells, minimizing damage to other cells in the body.
Precisely. And these monoclonal antibodies, they're showing very encouraging results in clinical trials.
That's great news. Now, what about supportive care? How important is that in managing AL amyloidosis?
Supportive care is super important. It's all about managing the symptoms and complications that come with the disease, like heart failure, kidney problems, and things like that.
So it's about addressing those downstream effects of the amyloid deposits while also targeting the root cause with the treatments we discussed.
Exactly. This might include medications to help with things like fluid retention, controlling blood pressure, and regulating heart rhythm.
Okay, so it's a multifaceted approach.
Yeah.
Now let's talk about ATTR amyloidosis. How does the treatment picture look for that type?
Treatment for ATTR amyloidosis has really changed a lot in recent years. There's been a big shift towards targeted therapies.
Targeted therapies,
Meaning these therapies specifically target the TTR protein, either by stabilizing it or by reducing its production.
Okay, so two main strategies. Let's start with stabilizing the TTR protein. How do you do that?
We use these drugs called TTR stabilizers. They bind the TTR protein and help keep it in its proper shape.
So they're like those molecular chaperones, making sure the protein doesn't misfold.
Exactly. And a couple of these stabilizers, diflunisal and tafamidis, have been shown to slow down the disease and improve symptoms for patients with ATTR amyloidosis.
That's great. So what about reducing TTR production? How do you do that?
We use a different type of drug called TTR silencers. These drugs actually block the production of TTR in the liver.
So instead of trying to fix the misfolded proteins, you're stopping them from being made in the first place.
Exactly. And there are two TTR silencers, patisiran and inotersen, that have been really effective at reducing TTR levels and slowing down the disease.
That's amazing. So it sounds like there have been some big breakthroughs in treating ATTR amyloidosis.
There really have. And the research continues, so even more promising treatments are likely on the way.
Okay, before we move on, any other emerging therapies for ATTR amyloidosis worth mentioning?
Yeah, there are a few others that are getting a lot of attention. One interesting approach uses a combination of doxycycline and TUDCA.
Doxycycline, isn't that an antibiotic?
It is. But it turns out doxycycline also has some surprising effects on amyloid fibrils.
Really? Like what?
Studies have shown that it can actually help break down those amyloid fibrils and clear them from the body.
Wow, so it's a double-duty drug. And what's TUTCA?
TDCA stands for torsodioxycholic acid. It's a bile acid that's naturally found in our bodies, and it has some protective effects on cells.
Okay. And how does it work against amyloid?
Well, when you combine doxycycline and TUDCA, they seem to be even more effective at removing those amyloid deposits than either drug alone.
So it's a 1-2 punch.
Yeah.
That's cool. Any other approaches being explored?
Yeah, there's a lot of ongoing research in this area, with scientists investigating new drugs that target different aspects of the disease process.
Sounds like there's a lot of hope on the horizon for people with ATTR amyloidosis.
Definitely. And the cool thing is that what we're learning about ATTR amyloidosis could also help us treat other diseases caused by protein misfolding, like Alzheimer's and Parkinson's.
Wow, that's amazing. So by studying one disease, we could unlock the key to treating many others. Okay, so we've talked about treatments for AL and ATTR amyloidosis. Are there any general management strategies that are important for both types?
Yes, definitely. The lecture really emphasizes how important it is to carefully manage those heart failure symptoms.
Right, because that's a common complication of cardiac amyloidosis.
Exactly. But the tricky part is that many of the standard medications for heart failure, they don't work so well in people with cardiac amyloidosis.
So doctors have to be really careful about what medications they prescribe.
Right. Another challenge is managing arrhythmias, which are irregular heart rhythms. These are common in cardiac amyloidosis, especially the ATTR type.
What kind of arrhythmias are we talking about here?
Atrial fibrillation is a big one. That's where the upper chambers of the heart, the atria, they just quiver instead of beating properly.
And that can cause problems.
It can. It increases the risk of stroke.
So people with cardiac amyloidosis and atrial fibrillation, they often need blood thinners to prevent those strokes.
Exactly. And pacemakers are also often needed because the amyloid deposits can mess up the heart's electrical system.
So those pacemakers help keep the heart beating at a normal rhythm.
Right.
Okay, makes sense. The lecture also mentions orthotopic heart transplantation and autologous stem cell transplantation. Can you talk about those?
Sure. Orthotopic heart transplantation is basically a heart transplant.
So that would be for people with very severe cardiac amyloidosis when their heart is failing.
Exactly. It's kind of a last resort when other treatments haven't worked.
But it's not a perfect solution, right?
Well,
Because amyloidosis is a systemic disease, so even with a new heart, those amyloid deposits could still affect other organs.
that's right. It's a big concern. And that's why doctors have to be really careful about who they choose for a heart transplant.
Okay, and what about autologous stem cell transplantation? We talked about that earlier for AL amyloidosis. Does it apply to ATTR amyloidosis as well?
That's a good question. Autologous stem cell transplantation is really only used for AL amyloidosis.
Because it targets those plasma cells that are making those light chains.
Exactly. And since ATTR amyloidosis is caused by a different protein, TTR stem cell transplantation wouldn't really help.
Okay, that clarifies things. So we've covered a lot on treatments and management for both AL and ATTR amyloidosis. But now I'm curious, with all these advances in targeted therapies, what does this mean for other diseases?
That's a great question. You know, cardiac amyloidosis is just one example of a protein misfolding disorder.
Right, we've talked about that.
And there are a lot of other diseases that are caused by the same basic problem, like Alzheimer's disease, Parkinson's disease, and Huntington's disease.
So there's a whole family of diseases with that common thread of misfolded proteins.
Exactly. And the things we're learning about treating cardiac amyloidosis, they could potentially help us treat those other diseases as well.
That's really exciting. So studying one disease could lead to breakthroughs in many others.
Yeah, it really shows you how connected everything is in science.
It's pretty amazing when you think about it.
One discovery can lead to all these other breakthroughs in totally different areas.
Absolutely. Okay, so before we wrap up this deep dive into cardiac amyloidosis,
Yeah.
I want to circle back to diagnosis for a minute.
Okay.
The lecture highlights a few key tests and findings that can really help differentiate cardiac amyloidosis from other heart conditions.
Right. There are some pretty specific things to look for.
Let's start with the ECG. What's the big giveaway there?
Well, as we mentioned before, one of the classic findings is that low voltage ECG.
Especially when it's seen with thickened heart walls on echo.
Exactly. It seems counterintuitive, but it makes sense when you understand how the disease works.
Right, the heart is electrically quiet, even though it's physically enlarged. Remind me why that happens again.
It's those amyloid deposits. They interfere with the electrical conductivity of the heart muscle.
Ah, right. So that's why you get those low voltages on the ECG.
And at the same time, those amyloid deposits are causing the heart walls to thicken, which is why you see that difference between the ECG and the echo findings.
So it's a pattern that doctors should definitely be aware of. What about echocardiography itself? What are some of the signs that point towards cardiac amyloidosis?
Echocardiography is really helpful because it can show a number of very specific features.
Like what?
Well, we've already talked about thickened heart walls,
Right.
but it's not just about how thick the walls are, it's also about the pattern of thickening.
Okay, what do you mean by that?
In cardiac amyloidosis, you often see thickening that extends beyond just the left ventricle. It involves the right ventricle and even the atria.
So it's more extensive than the thickening you might see in other heart conditions.
Right. And then there's the size of the left ventricle cavity.
Okay.
That chamber is often smaller than normal in cardiac amyloidosis because those amyloid deposits are limiting how much blood it can hold.
So the heart can't fill properly.
Exactly. And finally, there's the filling pattern.
Right, we talked about that.
In cardiac amyloidosis, you often see this restrictive filling pattern, meaning the heart is stiff and can't relax properly to fill with blood.
So it's having trouble taking that deep breath, so to speak.
Perfect analogy.
Okay, so we've got thickened walls, a small left ventricle, and a restrictive filling pattern. Those are all red flags for cardiac amyloidosis.
Yes, definitely things to look out for on echo.
And then there's strain imaging, which can show us that apical sparing pattern.
Right, where the tip of the heart is relatively preserved.
It's like a tip of the spear is still sharp.
Exactly.
Okay, so echocardiography gives us a lot of information. What about cardiac MRI? How does that help?
Cardiac MRI or CMR is really powerful because it can give us these incredibly detailed images of the heart.
And that helps us see.
It can actually show us the amyloid deposits themselves.
Wow, really? So you can see the actual buildup in the heart?
Yes, we can. CMR uses a contrast agent called gadolinium,
Right.
and that gadolinium highlights those areas of abnormal tissue, making them stand out on the images.
So it's like we're shining a spotlight on those amyloid deposits.
Exactly. And the pattern of that enhancement, which we call late gadolinium enhancement or LGE, that pattern can be very specific for cardiac amyloidosis.
Okay, so that's really helpful for making the diagnosis. And CMR also provides a really detailed assessment of heart function.
Right, absolutely. It can show how well the heart is contracting, if there are any blockages in blood flow, and so on.
So it gives us a very comprehensive view of the heart.
It does.
What about nuclear imaging? What role does that play in diagnosing cardiac amyloidosis?
Nuclear imaging can be really helpful too, especially for diagnosing ATTR amyloidosis.
How so?
Well, we use these special tracers that are attracted to bone.
Okay.
And it turns out that these bone-seeking tracers, they also bind to amyloid deposits in the heart, especially in ATTR amyloidosis.
Interesting. So you eject these tracers, and they go find the amyloid.
Exactly. And when they bind to the amyloid, they create this bright signal that we can see on the scan.
So it's like a homing beacon for amyloid.
That's a great way to put it. And what's even more helpful is that these tracers, they bind much more strongly to ATTR amyloid than to AL amyloid.
Ah, so that helps you figure out which type it is.
Exactly. And nuclear imaging has a couple of big advantages.
Like what?
Well, first of all, it's non-invasive.
So no needles or biopsies.
Right. And second, it's very sensitive, meaning it can detect even small amounts of amyloid.
Okay, so we've got ECG, echocardiography, CMR, nuclear imaging. Lots of options for detecting cardiac amyloidosis.
We do. And the more tools we have, the better our chances of making an early diagnosis.
And as we've discussed, early diagnosis is crucial for improving outcomes.
Absolutely. The earlier we can catch it, the better.
Well, I think we've covered just about everything on cardiac amyloidosis. It's been a fascinating deep dive.
It has.
And I hope our listeners feel like they have a much better understanding of this complex condition now.
I hope so too.
And remember, if you're ever worried about your heart health or if you have a family history of cardiac amyloidosis, talk to your doctor.
Early detection is so important.
Couldn't agree more. Well, that's another deep dive done and dusted. We'll be back soon with another fascinating topic.
Looking forward to it.
Until then, stay curious and keep diving deep.